Hello, my name's Tim Stockwell. I'm an emeritus professor of psychology at the University of Victoria and a scientist for the Canadian Institute for Substance Use Research. I want to talk to you today about an issue that's receiving a lot of discussion in the media and in public health and medicine, the idea that alcohol in moderation is good for our health. And I'm going to talk about a study in which we test a theory, a skeptical theory about what generates these findings. Some of you may have heard of the idea of the J-shaped curve, which illustrates how moderate drinkers live longer, appear to be healthier than abstainers, although heavy drinkers have worse health than other people. So I'm going to present a comprehensive review of all studies that related to the risk of death from all causes according to your level of drinking, and test a theory as to why some studies find benefits and others don't. So this idea about whether there are health benefits from alcohol has huge implications. It impacts national drinking guidelines, which go up or down according to assumptions about benefits. It impacts policy making. Warning labels have not been implemented in some countries for fear that health benefits may be lost by warning people to drink less. Global burden of disease estimates produced by the World Health Organizations leap all over the place. In 2020, there was an estimate of 1.8 million deaths globally from alcohol, with an assumption, this was published in The Lancet, that alcohol protected against heart disease up to 9 drinks per day. 4 years earlier, they'd only assumed it was up to 5 drinks a day, and there was an extra million deaths in 2016. But worth noting, there are estimates of the benefits which say there's none, although they're non-significant, most small benefits at 1 drink per day. This idea of the J-shaped curve, here's a classic example that was used in Australia many years ago as a basis of the low-risk drinking guidelines. And the idea was to recommend that people drink up to a level at which risks of mortality are the same as those of an abstainer. So you get this is showing the different graphs for females and males, and it was at approximately 3 drinks per day for men, 2 drinks for women. At that time, small Australian standard drinks is where the risk was the same as abstainers. So this was the basis of low-risk drinking guidelines back then. So we have a theory, we call it lifetime selection bias, about how this J-shaped curve appears. And it's the idea that there's systematic bias that accumulates across the life course. So the green line here shows the apparent health status at different ages. If you get a group of people at 15 who are moderate drinkers, or 50 or 75, over time, a sample of moderate drinkers gets healthier. Similarly, over time, a sample of abstainers shows reduced health. And it really accelerates in older age, people who've become abstainers. And the theory is about how people shift. They cut down or stop their drinking as they become frail or unwell, which results in a very biased comparison between abstainers who are increasingly unhealthy and moderate drinkers are becoming increasingly healthy if you don't take account of a lifetime pattern of drinking. So that's just the big general idea. We published a protocol for this study. It was a systematic review and meta-analysis. We identified thousands of studies which met provisional criteria, but our strict eligibility criteria resulted in us ending up with 107 relevant studies, which we coded for whether they had high or low quality characteristics according to our theory of selection bias. And I'm going to present 2 meta-analyses, one looking at a group of good studies, unfortunately there weren't many, and one looking at a group of the worst of the studies that had none of the high quality criteria. I want to acknowledge a major influence in this line of work, Dr. Kay Middleton-Fillmore, who was a medical sociologist at the University of San Francisco. She passed away 12 years ago, but I learned from her, and the methodology that we applied in this study and have over the last 2 decades for similar studies is to have very strict criteria for who is a sick quitter or if there's former drinker bias. So, for example, if people report almost never drinking or never having as many as 12 drinks in 1 year, we don't count those as lifetime abstainers. First, I'm going to show you some simple descriptive results looking at 4 study characteristics. We start with cohort age as to whether the population used in a cohort study was below 56 or 56 years and older. And there's a significant difference as we predict younger populations have had less chance when their drinking is assessed at a younger age. There's less selection bias because this process of becoming frail and stopping drinking hasn't yet kicked in to the same degree. Significantly higher risk of mortality for the cohorts selected at a younger age and those selected at an older age. Start with baseline illness of people sick before the study entry. If such people were excluded, they had a higher mortality risk. The low volume drinkers had a significantly higher risk of death than those from studies which had included people who were already sick. So that would create bias. So the last one is really the most important as to whether there was steps were taken to reduce abstainer bias or the sick quitter effect. And you can see that there's no significant benefits, the blue column, for the moderate drinkers, low volume drinkers in studies which had controlled for this, whereas there's substantial benefits apparent in the studies that failed to address this problem. So that's just simple descriptive unadjusted estimates. I'm now going to show you the main results. These 2 meta-analyses, we applied just 3 criteria. If we applied any more quality criteria, we'd run out of studies. We end up with 5 high-quality studies, and as you'll see, the risk curve, even low-volume drinkers have a higher relative risk of mortality, not significantly higher than the abstainers, but there's no reduced risk. And it's just, a linear increase in mortality risk with greater consumption. The most biased studies, the studies we coded as having the lowest quality, had substantial and significant reduced mortality risk for low-volume drinkers. I'd just note that we'd also presented a meta-analysis for non-smokers compared with smokers, and we had a similar straight-line linear increase in risk for non-smokers, whereas smokers, studies that included smokers, even with adjusting for smoking status, found a J-shaped curve, which has interesting implications. So I'm just going to end here with just noting that the results of this large systematic review, we found more studies than any previous meta-analysis on alcohol and all-cause mortality. The results support our lifetime selection bias hypothesis that health benefits appear and falsely in relation to low-volume alcohol use in the J-shaped curve. And this J-shaped curve vanishes in higher quality studies that have taken steps to reduce bias. Conversely, lower quality studies find markedly reduced mortality risk for lower volume drinkers. This problem plagues almost all alcohol epidemiology. It's not just studies on cardiovascular disease, it's also cancer. And the implication of that is that our estimates of the health impacts of alcohol are underestimated across the board because the majority of studies do not address this problem very well. So I conclude with the thought that we need more high-quality studies on this topic to confirm these findings, not just in this area of observational research, but also in genetic and randomized control study designs, which also tend, with the better designed examples, tend not to find benefits from alcohol. So the final practical implication clinically is to be very skeptical of the idea that there are health benefits from low volume, moderate drinking, and to help patients improve their health or reduce current or future risks of cardiovascular disease, for example, or diabetes, that they take other measures like better diet and exercise and not use alcohol as a means to improve their health, as it's unlikely to do so. So anyway, thank you for your attention. This study is published and you can find it online. Thank you very much.